Okay, thank you very much. I feel privileged to be invited here to give my talk in this great anniversary. And my talk is totally clinical, not so basic. And please allow me to introduce our experience. And this is the number of childbirth in Japan. So we are a country of declining birth rate. And last year, so 0.68 million, which is very small as compared to 10, 20 years ago. And the birth rate is 1.15, still over 1, but not such a good news. And the other side of the childbirth story is that the number of childbirth by IVF-ICSI is increasing these couple of years because of the introduction of health insurance coverage system for IVF-ICSI in Japan since 2022. And so this is the main part of my story. And the graph shows development of fertility preservation in Japan, and the time course is from left to right. And as you know, in 2006, Fertiprotect was developed, established in Germany, and 2007 in the US, Fertility Consortium was established. And these were the momentum to put the fertility preservation into clinical practice. And pushed by this momentum in Japan, in 2012, Japan Society for Fertility Preservation, JSFP, was established by the leadership of Nao Suzuki. And 2017, Oncofertility Guideline was published by Japan Society of Clinical Oncology. And after that, 2018, Japan Fertility Registry System began. And 2021, a government subsidy for fertility preservation in oncofertility started. And this is the big change in the field of reproduction in Japan. And National Health Insurance for IVF-ICSI started this year. And more interestingly, so 2023, Tokyo Metropolitan Government started the subsidy for planned oocyte cryopreservation, not only for fertility preservation for oncofertility. Okay, so I'd like to explain one by one. And first, so this is JSFP, which was established as a hub for a medical healthcare network for young cancer patients. And the network comprises child, adolescents, and young adult cancer patients, which is center. And around these patients, oncologists, healthcare providers, such as nurses and psychologists, and so on. And fertility specialists and researchers are there. And as a connection point, JSFP provides symbiosis, relief, and safety for the society and for the patients. And now the society has more than 1,000 members. And JSFP is currently working on multiple missions to promote oncofertility in Japan. And the first, construction of registration system to evaluate the outcome. And next, perinatal committee is working to avoid the risk of pregnancy and childbirth for cancer survivors. And Onco Women's Health Committee is to improve women's health care for cancer survivors. And education for nurses, pharmacists, and epidemiologists and genetic counselors are a very important part of the JSFP, developing human resources for healthcare professions in oncofertility. And we established a system for oncofertility navigator, which we have a certification system and which support us to enlighten the society. And adoption and foster parent committee is to increase future options. And a big step towards the spreading of oncofertility in Japan was by publishing the oncofertility guideline by the Oncology Society, not by the Reproduction Society. So the reason is that the impediment of widespread of oncofertility was a lack of awareness and knowledge of oncofertility in oncologists. So we asked the Oncology Society to make it. And JSCO, Oncology Society, has developed guidelines in the form of recommendations for addressing clinical questions in various areas. And most of the work was done by reproduction doctors in collaboration with oncologists. And the revised version was published last year, and there a few new areas were added. Okay. And here we examined the effect of the guideline. It was remarkable. And we studied the impact and published it a couple of years ago, where we conclude that the practice of fertility preservation in cancer patients in Japan has been considerably affected by the first Japanese guidelines, not only in the oncology field, but also in our reproduction field. And this is an example. The methods for ovarian stimulation have changed after the publication of the guidelines, and specifically the use of aromatase inhibitors in breast cancer patients in ovarian stimulation significantly increased after the publication of the guideline. As shown here, for embryos before the guideline, 62.9%, which increased to 83% after the guideline, and for oocytes from 68.3% to 92.4%. And likewise, the usage of random start had increased a lot in hematologic malignancy. And before the guideline, it was 46.9% for embryos, which was 79% after the guideline for oocyte, from 52% to 91%. So the guideline had a big impact in our society of reproduction. And in 2001, Japanese government started the subsidy program for fertility preservation based on medical reasons. And the subsidy program started as shown here. In 2020, 4 academic societies related to oncofertility submitted the request to Japanese government. Japan Society of Obstetric Gynecology, Japan Society of Reproductive Medicine, Fertility Preservation. This is a Urology Society. And at that time, here, I was the president of Japan Society of Reproductive Medicine, and so I endorsed the request for financial support for the fertility preservation of Kaya. And pushed by our request, the government decided to start the financial support as shown here. And this is the list of the subjects eligible for the fertility preservation subsidy program due to medical reasons. And the first one is treatment indicated in the guideline, which I've shown. And the second one is cancer in which long-term treatment is expected to reduce ovarian reserve. And the an example is breast cancer patients treated by tamoxifen for a long term in their 30s. So maybe during that time, ovarian reserve would decrease a lot. And also, in this table, as you can see here, non-cancer diseases for which hematopoietic stem cell transplantation is performed, and the non-cancer diseases in which alkylating agents are administered are also the subjects of this program. Okay, so this is a kind of real world story, and the amount of subsidy is here, and I calculated by Korean won, and so sperm freezing 50,000 yen, maybe this is correct, maybe, right? Okay, and for oocyte freezing, so the subsidy is up to 300,000 yen, which is, so sorry, not in dollars. Okay, so you can calculate, maybe. Okay, so this is our system. And along with the development of the system for fertility preservation, we started the registry system here for oncofertility in 2018. And the name is JOFR, and the abbreviation of the Japan Oncofertility Registry. And the point is the registration is mandatory when the patient is treated with a subsidy program, which means that all patients are registered to JOFR. And using this registry, we analyzed the trends in fertility preservation treatments in Japan. And in this study, we used the data from 2018 to 2023. And the correspondence of this paper, Professor Miyuki Harada, is my successor in the Department of OBGYN at the University of Tokyo. And these are the methods of fertility preservation. And as you can see here, sperm cryopreservation is the highest in number, followed by oocyte cryopreservation, which counts up approximately half of sperm cryopreservation. And the number of embryo cryopreservation is a little less than that of oocyte preservation. And the number of ovarian tissue cryopreservation is much less. And oncotese is far less in number. And this is the time course change of the number of patients undergoing fertility preservation for oncofertility treatment in Japan. And the number is steadily increasing, reaching around 800 per year in both sexes, with a bit fewer in males compared to female. And the lower graph here shows the number stratified by the method of fertility preservation. And the sperm preservation is most common throughout the time course. And this is the age distribution. In males, the number sharply increases at ages 16 to 20, and this reflects the onset of spermatogenesis. And the peak is at ages 26 to 30, and then the number decreases thereafter. In females, the number remarkably increases at age 31 to 35 and at ages 36 to 40. The reason here is that many breast cancer patients are in those ages. And I will address the issue again later. And this is the breakdown by methods in males. The method used is primarily sperm cryopreservation, and with the distribution similar to that in males. And the number of oncotese here, oncotese, is a very tiny number, but widely distributed from the ages 11 to 15 to over 46. Okay, and with regard to testicular tissue cryopreservation, only few is shown in ages 6 to 10 and 11 to 15. And this is the breakdown by methods in females. The number of oocyte cryopreservation and that of embryo cryopreservation are both highest at ages 31 to 35 and ages 36 to 40. And ovarian tissue cryopreservation is small in number, but widely spread throughout all ages, starting from ages 0 to 5. And this graph shows primary diseases of patients undergoing fertility preservation in Japan. In males, leukemia, lymphoma, and testicular tumors are the top three, counting 1,760 and over 1,000. In females, breast cancer shows tremendously large number. The number of leukemia and lymphoma are shown here, counting almost the half of that of males. And this graph shows the age distribution in each disease in male patients undergoing fertility preservation. In the top three diseases, the trend is similar, with ages 20s and 30s being the major portion. And in leukemia, patients in their teens occupy not a small portion here. And in females, the majority of breast tumor patients undergoing fertility preservation in their 30s. And it should also be noted that not a small number is over 40. And the figure shows the time from diagnosis of the primary disease to its treatment, and the time from diagnosis to fertility preservation treatment, which is very important, as Professor Al-Hendis taught already. And as you can see here, compared to male patients, female patients tend to have longer days between diagnosis and disease treatment. And the tendency is the same in the days between diagnosis and fertility preservation. And this might be because a significant proportion of women undergoing fertility preservation have breast tumors, breast cancers. So in breast cancers, they have time to consider and so to wait for fertility preservation. But otherwise, they doesn't have enough time to have fertility preservation probably. And what the complications and outcomes in fertility preservation in treatment in Japan. And clinical pregnancy has recorded as 760 cases, and while 440 among them are using preserved specimens. And discard rate is 16.3 for men and 3.7% for women. And for complications, OHSS 5%, bleeding 0.1%, and infections 0.05% for women have been reported. And I again show this slide. Please look at here. The bottom one is non-cancer disease in which alkylating agents are administered. And these diseases are usually treated by not OB/GYN, of course, and by rheumatologist or internal physician. So in order to examine how doctors treating those patients are aware of oncofertility in Japan, we conducted a national survey. And questionnaires were sent to certified educational facilities of Japan Society of Rheumatology. The response rate was not high, very low, while 65.1% of respondents had the experience of gonadotoxic therapies in recent years. And the graph shows a result in terms of the diagnosis. The number of patients who had undergone gonadotoxic therapies was the largest in SLE. And black bars represent males and white bars premenopausal females. And the number is much higher in females with diagnosis of SLE. And while the difference was much smaller in other diseases. And we asked how they explain fertility preservation to patients. And as you can see here, explanation on fertility preservation was conducted by rheumatologists, other doctors, and was not conducted at all, with around a third in each. And other doctors are probably OB/GYN doctors. And regarding fertility preservation methods explained by rheumatologists, oocyte preservation showed over 80%, seemingly very popular. Sperm cryopreservation and GNH analog were also often explained. And in terms of availability of fertility procedures, about half reported that GNH analogs were available either in their own institution or at a nearby institution. And meanwhile, only less than a third here of the respondents reported that other fertility preservation procedures were available within their institution and a nearby institution. So only less than a third answered that. And many respondents here indicated that they were unsure whether fertility preservation procedures were available at their institution or in nearby locations. And these are the factors that prevent patients from receiving fertility preservation procedures in the rheumatology field. And not enough time to consider, and economic burden, lack of facilities, and lack of knowledge, lack of information, and lack of data regarding fertility preservation in patients with autoimmune diseases. So this is the status quo of rheumatology field in Japan. So we are now trying to educate or enlighten other field more and more. And in endometriosis, fertility preservation is getting more attention to preserve fertility of patients. However, fertility preservation for endometriosis is seldom conducted in Japan. Why? First, I just want to show the guideline or the proposal of a French group. And this is a good approach, I think, practical approach to fertility preservation in presurgical endometriosis patients. And they say that the good candidates are bilateral endometriomas, unilateral endometrioma with a history of surgery for contralateral endometrioma, multiple surgeries, a risk of multiple surgeries, and or the low ovarian reserve and aged over 70 or over. Okay? So, however, in these days, so the mainstream of endometriosis treatment in Japan is by medical treatment, but not surgery. So the case fitted, so very suitable for fertility preservation in endometriosis is very rare. So of course, we do in very rare cases. So if we have a patient, so the bilateral endometrioma surgery is necessary, we propose this kind of fertility preservation. But otherwise, we use medical treatment, which works very well, and we have many new good drugs now. Meanwhile, what we often do for endometriosis patient is ECBIS. This part is a little bit out of scope of oncofertility, but I'd like to show our data. And ECBIS is more for improving IVF outcomes than for preserving fertility. And ECBIS is the abbreviation of embryo cryopreservation before surgery. And first, we practiced this procedure for myomectomy patients because we usually treat myoma patient by GnRH agonist or antagonist 2-3 months before surgery, and do embryo transfer 3 months after surgery in order to confirming the healing of the wound of the uterus. But very recently, we also applied this ECBIS technique to endometrioma surgery. And in this case, purpose is to improve the uterine environment for implantation. What is the rationale? Maybe already many times this story has explained in today's lectures. So in endometriosis patients, the dysfunction of the endometrium is often found, and we thought that the extirpation, so cystectomy of endometrioma, would reverse or normalize the endometrial function. So we did this study with a protocol here. Unfortunately, this is a retrospective study, and the subjects, however, the subjects were patients aged 28 to 42 who had endometrioma and underwent OPU for IVF. And all the embryos were frozen. And each patient chose whether to undergo surgery or not after the explanation of ECBIS by the doctors. And ECBIS group received frozen embryo transfer after cystectomy, and the control group received frozen embryo transfer without surgery. So what the result is also, and this is the background. And as for the background, the patient's characteristics are not different between the groups except for the maximum size of the cyst. And the size was larger in the ECBIS group, 59.4 compared to 33.6 millimeter on average in the control. This is the cumulative pregnancy rate. And as you can see here, it takes a couple of months for the patient to prepare for and recover from surgery. And so the rise of the curve is later in the Equus group. But the cumulative pregnancy rate of the Equus group surpassed that of the control at around 6 months and remained higher throughout observation period. So maybe the effect of endometrioma surgery improved the status or environment of the endometrium. And as shown in the red figures here, according to the, as shown in the red figures, the miscarriage rate was lower, and the clinical pregnancy rate and ongoing pregnancy rate were both higher in the Equus group. And we examined the factors contributing to the ongoing pregnancy, and in univariate analysis, age, number of embryos, and Equus were involved. However, in multivariate analysis, only Equus were involved. And I think Equus is an option in treating infertile women with endometrioma who is going to have IVF-ET. And finally, I briefly address planned oocyte cryopreservation in Japan. So planned oocyte cryopreservation was said like social oocyte cryopreservation, but in my country, now we are moving to using the term planned oocyte cryopreservation. And this graph shows the number of oocyte cryopreservation in Tokyo and that outside Tokyo, and divided by the indication. Okay, so this is for onco, and this is planned. Okay, so in Tokyo, the number of POC is around 9 times higher than that of oocyte cryopreservation for oncofertility treatment. In contrast, the number are equivalent outside Tokyo. Okay, so demand very high in Tokyo. And so Tokyo Metropolitan Government started a subsidy for POC in 2023. Women between the ages of 18 and 39 living in Tokyo are eligible. And subsidy amount is 200,000 yen. And Tokyo Metropolitan comprises many cities. And Minato City started subsidy for POC in addition to the subsidy provided by Tokyo Metropolitan Government, which is up to 100,000 yen per person. Minato City is a very rich area. It's very hard to live in. So I am living in outside Minato City, of course. And so Tokyo City citizens can receive subsidies for planned egg freezing. And this graph shows total cost of egg freezing in each facility in different clinics. And most which are private clinics, and an average is around, median. Median is around 300,000 yen, which is the same as the maximum subsidy of the Minato City citizen. Okay? And Tokyo City citizen living outside Minato City can receive 200,000 yen, which is two-thirds of the cost in median here, in red line in many clinics for egg freezing. And look at here, So this is the number of applicants subsidy shown here, and most of them, two-thirds of them are over 35, between 35 and 39. And I think this is not so effective in terms of future pregnancy. But in any way, what is the general landscape in Japan is shown here, and this is consequences of non-medical also planned onset preservation, one Japanese clinic. And here the data is from 2014 to 2021, and before the subsidy program. And return rate was 26%, and utilization rate was 15%. And among them, birth rate was 21%. And when I compared the figure with the figures in the world, the age at oocyte retrieval are almost same. Thawing is almost the same, and the number of users percentage is almost equivalent, and live birth rate was not so different. So Japanese environment is similar to the world environment in general. And here the summary. So fertility preservation for oncofertility is gradually but steadily in progress in Japan. The key factors promoting oncofertility practice in Japan are activities of JSFP. So I am now the supervisor and advisor of this society, and the oncofertility guideline, the registry system, and the financial support from the government. And breast tumor is the main primary disease of women undergoing fertility preservation in Japan. And ECBIS is an option for IVF-ICSI in women with endometrioma. And the number of planned oocyte cryopreservation is increasing, especially in Tokyo, partly due to subsidy by local government. Thank you for your attention.